So now that we have seen the classification of retinoblastoma, we've seen the varied ways in which it can present. So my task here is made simple by Dr. Anirban and Dr. Fairuz. I will just try to simplify as much as possible the treatment approach that we take when we diagnose a patient of retinoblastoma. First thing to note is that when we read literature coming from the Western countries, we find that they report a cure rate of almost 100% for these cases. But when we compile the global data, as has been published, the cure rate comes down to about 30%. So that is really dismal. And what happens is that most of the developing countries, in which India is also part of that spectrum, so the results are not as good as what we see coming from the Western countries. That's primarily because of late detection and so many other socio-economic factors that we see in countries like India and other neighboring countries. So when we're talking about any kind of treatment, any kind of cancer, mainly there are three goals. That's the first goal is to save the life of the patient, the second is to save the eye, and the third is to save the vision or the sight of the patient. And then we have to, when the patient comes in, there are a lot of factors which we need to take into consideration, which will influence our treatment. Most important are staging, proper staging and grouping. Number two is the germline mutation, if the patient has a hereditary tendency or not. And then the socio-economic factors as the background from where the patient is coming from. And then whatever best resources we have are at our hand to treat. So all these factors we need to keep in our mind when we are deciding about treatment for any particular patient of retinoblastoma. And the text that we read or the books that we read or when we listen to the speakers from abroad, the way they are treating their patients is so very different from what we can achieve in our country because of various limitations, socioeconomic limitations, the patients from where they come from, their economic profile and all those things. Our factors are really different. So what I am presenting here is the treatment in the practical sense that we are able to follow in India, that we are able to manage in our setting, and not some ideal thing that we see in the publications or the textbooks. So some common pre-treatment factors that we need to take into account, as some of them Dr. Anirban also mentioned and Dr. Usha also stressed upon. First thing is family history, something which one can easily take in the OPD. Whenever a patient of retinoblastoma is there, sometimes we just jump onto the IUAO, do this, do that, but we forget about very important aspect, the family history. Does the child have a sibling? Does the child have a parent who was affected? If there is a sibling, how old is the sibling's age? And so you need to take all those considerations into mind and then plan your treatment. And then you do a detailed evaluation under anesthesia, where you do a detailed indirect ophthalmoscopy with depression, and you group the tumors as Dr. Fairuz showed according to ICRB staging and grouping. B-scan is easily available and already stressed upon what you need to look for. Need to look for calcification. And an MRI is essential to rule out an optic nerve invasion, an extraocular extension, or a pinealoblastoma in bilateral cases to plan proper treatment for these cases. Now, when you see a very small tumor, so very small tumor, that's like group A. So we have two very good modalities to treat these tumors, very small ones, peripheral tumors, 1 to 3 millimeter in size. So you can do cryotherapy, triple freeze-thaw cycles are given. And the only disadvantage is that with cryo, the scar produced is fairly large. So we have the other option, that's the laser transpupillary thermotherapy, that's the TTT, where we use a 810 nanometer diode laser, and the spot is delivered through a large spot indirect ophthalmoscope delivery system, which raises the tumor temperature to about 45 to 60 degrees, and that produces a subtle graying of the tumor. That's your endpoint. And for small peripheral tumors, simple TTT can be enough. For group A tumors, TTT also has a significant role as a focal consolidation measure along with systemic chemotherapy. Now, from group A, when we move on to the group B or further advanced tumors, that's a little larger tumors, we must know about the systemic chemotherapy that is available for these tumors. So systemic chemotherapy in a country like India is the mainstay of treatment. Still, we use 3 drugs conventionally, vincristine, etoposide and carboplatin, which are given under supervision of a pediatric oncologist. And then there is something called as chemocryotherapy. So when you are sending the patient for chemotherapy, if near the aura you put 2 spots of cryotherapy, that is supposed to increase the concentration of chemotherapy and the availability of the drug into the vitreous and to the tumor. So it's advisable to do that. Now, indications of systemic intravenous chemotherapy are if the patient has bilateral disease, if there is a confirmed germline mutation, even if it's a unilateral condition, if there's a family history of retinoblastoma, which again points towards a germline mutation, and if there is a suspected optic nerve, choroidal invasion, orbital invasion, or it's an advanced tumor, there again you require systemic intravenous chemotherapy. And there has been some talk about some protective role of in the prevention of long-term second cancers, though that is a little debatable. As we can see in this chart, the results with intravenous chemotherapy have been fantastic, with smaller tumors responding much better, and even in group E eyes also, there was almost 1/3 of those cases could have lasting tumor control where enucleation could be avoided. But then again, the management has to be tapered, so it's not just about chemotherapy. A newer thing that we have is intra-arterial chemotherapy, where you go directly into the ophthalmic artery and directly inject the drug, which delivers almost 10 times the concentration of dose into the eye as compared to the systemic chemotherapy. 1 or 3 drugs are given. Dr. Fairuz would be talking about the details of intra-arterial chemotherapy. I will not go into much details of that, but it's mainly indicated for non-germline, unilateral, group B, C or D tumors. And there are reports coming in of it being tried in some group E tumors, but as of now, the general indications are for group B, C or D unilateral tumors. Now, when we have a patient who's come to us with a slightly larger tumor, so what do? So it's a group B tumor, which is a little larger than the group A tumors, that's less than 3 millimeters, as Fairuz mentioned in the classification, if you recall. So this patient presented with a group B tumor. So the option that we have is intravenous chemotherapy. Along with, after 2 or 3 cycles of chemotherapy, you start the focal treatment as well, which is in the form of TTT laser. And this is how the tumor regressed. So what happens is that with chemotherapy, the tumor starts shrinking, and once it's shrunken to a sufficient extent after 2 or 3 cycles, then we start adding laser therapy also on the surface, and usually these tumors respond well. Another interesting option is the IAC. Dr. Fairuz will talk about it. IAC has fantastic results, but there are cost implications and logistical implications in a country like ours. The technical know-how is not available everywhere. Cost becomes a barrier. So still we are relying more on intravenous chemotherapy compared to intra-arterial chemotherapy. Group C are cases which have got some sort of seeds. C is confined seeds. So basically these are confined seeds, means the seeds are close enough, less than 3 millimeters away from the tumor. And for such tumors also, we have option of intravenous chemotherapy to control the main mass. And also, if the seeds are not responding just to conventional treatment with intravenous chemotherapy, we have 2 other things, that is the periocular chemotherapy or intravitreal chemotherapy. Also, if it's a small peripheral tumor with a small set of seeds just adjacent to the tumor, then you can actually cryo the tumor as well as let the ice ball grow into the vitreous and freeze the seeds also along with it. And again, IAC is a very good option but expensive one. Group D tumors are those where the seeds are more diffuse, and again there are options like you control the main tumor first with intravenous chemotherapy and consolidation with laser. And for the seeds, if they are not responding to the main treatment for the main mass, then you have to go for periocular chemo or intravitreal chemo, or IAC if it's available and the patient can afford, very well. Or if the tumor is still very resistant, or the patient is somebody who's not able to come for follow-up, if it's a unilateral disease, enucleation is still a viable option in cases which are really bad, not responding to treatment, patient not able to come for follow-ups. All those factors you need to keep in mind. Intravitreal chemotherapy is something which recently has come into vogue, and was first introduced in 2003 by Kaniko. And so you have these vitreous seeds which are very resistant to to treatment at times, and you give intravenous chemotherapy, sometimes even after intra-arterial also you may have some residual vitreous seeds which are not responding because probably the drug concentration is not reaching those seeds enough, or they have some other form of resistance to chemo. So there intravitreal chemotherapy does help. So one is intravitreal chemo, you can give either melphalan or topotecan. 25 to 30 micrograms of melphalan is what is given, and 20 to 30 micrograms of topotecan. Sometimes you can give both the drugs together, and sometimes triple drug, which also adds carboplatin. The problem with melphalan is that it induces a lot of pigmentation on the retina, and after giving melphalan intravitreally, sometimes you see patients, especially in pigmented populations, so you see that the retina develops a lot of RPE changes, like similar to retinitis pigmentosa, and there are some changes on ERG also which have been noted. Other option is subtenon injection of carboplatin 15 mg, which is given almost once in every 3 weeks. So these are the two modalities which we can try, either intravitreal or subtenons or periocular chemotherapy for these vitreous seeds. The precaution that has to be taken is that when you inject the intravitreal chemotherapy for these retinoblastomas, your needle has to come out through the cryoprobe, through the cryo ice ball, and not just like that. And also there is a specific technique to give this injection, which is already detailed in literature. Group E tumors, the options are intravenous chemotherapy, especially if bilateral. However, if it's unilateral, then you can try either chemotherapy or enucleation. I would say if it's a very advanced disease, that's a better option rather than subjecting the patient to prolonged periods of chemo, when especially there is visual prognosis is not there, and unnecessarily prolonging the treatment. AC seeds, that's the anterior chamber seeds. Dr. Anirban showed a few cases of that. So these cases are till now into group E, and the standard treatment protocol was, and still is, I would say, enucleation. But few reports have come in, and which gives us some hope for the future from Munier et al. And they've introduced intracameral chemo. There is a specific technique to give an intracameral chemo. They go from clear cornea into the iris and then inject the drug near the zonules without touching the lens. So there is some hope in that on that front, where we are still enucleating most of these eyes. So maybe in future we'll have a better management for anterior chamber seeds as well. Radiotherapy, external beam is very rarely used nowadays unless it's an orbital tumor, as it was used to be a mainstay of treatment in earlier days, but now only it's reserved for orbital tumors, mainly because of the risk of second cancers following radiation in such young children. What we usually prefer is plaque brachytherapy instead. That's the focal or localized form of radiotherapy, which does not have so many side effects as the external beam full orbital radiation. So, but it's basically used for tumors which are resistant to the conventional form of treatment, where you give intravenous chemotherapy, you have tried intravitreal chemotherapy, you've tried whatever best measures you have, you've tried laser and everything, but the tumor still keeps coming back. It's not responding. So then in those cases, plaque brachytherapy is a very viable option with a very good success rate. And enucleation, as I mentioned, for massive group E tumors or bad group D tumors, where actually visual prognosis is not there and the tumor is not responding to conventional treatment or chemotherapy, or there is poor tumor visualization, which is making it difficult to assess every time. So in patients of extraocular extension, as a part of multimodal treatment, not just if it's an orbital tumor, you don't straight away jump in for enucleation, but first you give chemotherapy. Dr. Honavar will talk about those cases, and it's part of that protocol. And if nothing else is working, it's an extensive tumor, you see that visual prognosis is not there. Instead of subjecting the patient to repeated cycles of intravenous chemotherapy, where the patient is coming every month, going back, and undergoing a lot of expenses as well as anxiety, it's better to just enucleate those eyes, especially if it's a unilateral condition. In bilateral, of course, you have to give it a try with chemo. The key thing here is that when you enucleate, you need to have a long optic nerve stump, more than 15 millimeters, what is recommended, and we normally put a primary orbital implant at the time of enucleation. And always subject the enucleated eyeball to a good pathologist who's experienced in seeing eyes with retinoblastoma. So what they will tell you is about confirmation of the diagnosis, that's first. Second, what's the differentiation of the tumor? Then what's the extent of disease, and if the patient has histopathological high risk factors. These are some of the factors which you see on pathology, which can predict, that which patient is likely to have micrometastasis. So if any of these risk factors present, that's optic nerve post-laminar involvement, anterior chamber seeding, ciliary body involvement, massive choroidal invasion, scleral invasion, or if there's an extensive tumor necrosis. All these patients, if they have this on histopathology of the enucleated eyeball, they are more likely to have systemic metastasis. So what happens if they have these? Then you go in for bone marrow and CSF analysis and a systemic evaluation, and you have to give these patients adjuvant chemotherapy, which significantly reduces the risk of metastasis from an untreated patient to 24% to about 6% if you give adjuvant chemotherapy in these cases. So this is basically just a table summarizing what I have just spoken. In addition to this IAC, what is more important for us here is intravenous chemotherapy. So to conclude, we have a wide variety of options, and we need to individualize the treatment plan based on so many factors which probably are unique to our setting. And so early detection is good, and response is usually good if we pick it up on time.